Welcome to Mental Health Helps, where we heal, educate, listen, prevent, and support through conversations with experts, activists, and people's personal stories. Welcome to Mental Health Helps. I am Brandy Vega. Today in the studio, we have Dr. Mindy Westlund Schreiner. Thank you so much. You are joining us from the University of Utah. And tell us what your specialty is.
So my research and also my clinical work, I guess, focuses specifically on self-injurious thoughts and behaviors, or SITBs, in youth. So suicidal thoughts and behaviors, also non-suicidal self-injury in teenagers particularly, and also understanding how to best treat those behaviors, in addition to understanding what's going on a neurobiological level.
Okay, that was a lot. What is classified as a SITB?
So SITBs include suicidal ideation, so thoughts of suicide, and also suicide attempts or suicidal behaviors, and then also what we call non-suicidal self-injury, which is most of the time it takes the form of cutting or hitting or burning oneself. And then sometimes it's more ambiguous. It's not suicidal or non-suicidal. It's somewhere in the middle.
Okay. How did you get involved in all of this? There's always a story, a backstory about how you wound up in this field.
Yeah, so there's a very long version, so I'm going to try to do a shortish version. So part of it is personal experience with family members, things like that. Also, I grew up in a rural community in northern Wisconsin, actually, and resources growing up were very poor, and also SITBs, as we call them, were pretty not well understood, and access to care was also virtually non-existent. And then also navigating the mental health field, even as I was in grad school, on behalf of a family member, really made things interesting as far as wanting to become more involved in mental health access, things like that.
Okay. So then you wound up here in Utah.
Mm-hmm.
And what is it that you do daily at the U?
Daily at the U, a typical day doesn't exist. But I would say a lot of the time I spend working on research-related activities. So that includes like working with our staff and also looking at brains, which is a lot of fun. So one of the studies that I have kind of just starting now is looking at brain functioning before and after treatment in adolescents who were recently discharged from the inpatient units at Huntsman Mental Health Institute, and that also looking at how well that particular treatment works for targeting self-injurious thoughts and behaviors.
What are you noticing?
So it's relatively early on. We just got approval today to proceed with the new and improved version of the study.
Congratulations. That's exciting, right?
Yes. But what we're looking at specifically is rumination, or repetitive negative thinking, with the idea that ruminating is a risk factor for continued engagement in self-injury or suicidal ideation. Particularly because you can sort of think of suicidal ideation itself as a form of rumination. Just these repetitive thoughts of not wanting to be here, not being able to do anything about the situation, this sort of passive process of getting stuck and feeling like you're unable to do anything.
Tell us what, briefly, rumination is, how it works. I know you did, but is this what leads to the self-injurious, thoughts and behaviors, or is this something else?
So rumination is, as we think of it, persistent, negative, repetitive thinking. it's sort of getting stuck in this cycle of thoughts. Sometimes people describe it as a spiral, where you're just perseverating on the same thing over and over. And a lot of times it's something that you can't do anything about, but it's
like a Groundhog Day in your brain where the same thing just goes over and over.
And how appropriate of a comparison to use on Groundhog Day. But yes, it's this over and over cycle of thinking that usually isn't particularly helpful. It appears, research so far, it appears to both lead to and maintain self-injury. It's also extremely related to depression. So some of our work with adolescents with depression, we focus on rumination as our therapy because we find that individuals who experience depression and get better, they're of course at risk for having more depressive episodes. If they are experiencing more rumination, even when they're not feeling depressed, it's more likely that they'll experience a depressive episode. So one of the things that we do is we target rumination in an effort to then prevent those future episodes from happening.
So is rumination always a negative thing? Like you're stuck in this negative thought process or negative cycle? Or can you form it into a positive rumination where you're thinking about good things?
Yes. So, I mean, there's a helpful side to it. So it becomes unhelpful when you're doing it for more than 20 minutes is kind of like a general rule that we use. Or you're thinking about something that you can't do anything about. Whereas more helpful ruminating is more focused on solving a problem, like thinking, I'm going to do this and that, or how do I solve this? How do I make, how do I make someone feel better about this situation that's happening? In fact, a lot of what differentiates helpful thinking or potentially helpful rumination from unhelpful rumination is actually just the how versus why dichotomy. So unhelpful rumination is often focused on why, like, why can't I do this? Why does everything suck? Why is this happening to me? And so on and so forth. Well, one of the things we actually do is replace the why questions with how questions in our therapy. So things like, how am I going to make the most of this situation? How can I make things better? How can I do differently next time? And so I'm not sure if you noticed, but there's a different feel to the sorts of questions.
One is just spinning your wheels. Yes. The other one's actually getting traction to get out of the situation. Exactly. What are some identifying factors of self-injurious thoughts and behaviors?
Identifying factors, of course, is seeing the self-injury itself. So marks or unexplained bruises or scratches on arms, things like that. Another thing that we can sometimes see is that it's often associated with depression, for instance. So some things to look for doesn't necessarily mean that SITBs are occurring, but looking for warning signs of depression. So becoming withdrawn, persistent sadness, putting oneself down over and over, having low self-esteem can all be sort of signs that maybe it's time to check in and see how that person's doing.
And what are some of the signs, though, of if a child or even an adult is doing this? What are the things specifically that you would want to look for?
What I would want to look for is, I guess, in terms of figuring out whether or not the person is engaging or learning about the self-injury itself.
I think both, because I know for me, I have a daughter who's a cutter, but she hid it for a lot of years because she did it inside of her thighs. I wouldn't have thought to check, or to ask. So I guess, and for some people, they pull their nails off. For some people, they pull out their hair. Like, I don't know what are like the most, I mean, I think the most common is probably cutting and maybe like burning yourself or something like that. But I don't know specifically what we could tell people that if you see these things, maybe there's...
Yeah, it's really difficult because teenagers in particular are very good at masking, whether that be, self-injury or just their emotions. So making sure to have an open dialogue is really important, and also a tricky thing to start establishing. But having conversations about mental health as like a regular topic, just as you would talk about physical health, like aches, pains, things like that. And some of that is also modeling on the part of adults in that person's life. So, for instance, if, say, there is a parent who is struggling a lot with anxiety, being able to name it and also take care of themselves the way that they need to take care of themselves, to model that behavior to their children. And so they see, okay, this is something that I don't have to struggle with by myself, and there are ways that I can get help.
What are you hoping to, what is your end goal in all of this? With your job and your research, what are you hoping to accomplish?
I hope to reduce suffering is the really broad answer, but psychiatry is a very young field, and because of that, we really don't know as much as we need to know to make a significant impact on every patient that we see. So one of the things that I'm interested in learning more about is what sorts of interventions work for what specific people and why, to better tailor those interventions, whether it be a particular kind of therapy or a particular kind of medication or something like transcranial magnetic stimulation, things like that. What was essentially learn how to play matchmaker in terms of what is the person struggling with, what sort of features they have, not just on the level of asking questions, things like that, but actually understanding the biological factors at play to better tailor those interventions to optimize treatment response.
So honing in on some of the root causes and then finding treatments that resonate or fix that. And I think it makes me curious with what you're talking about. I mean, we only know what we know, and a lot of it is just get therapy or get counseling. Oh, you have a problem? Get this. It sounds like you're talking about a few other things. What are some other treatments maybe that we're not totally familiar with that parents can say, I've tried this with my kid or with my spouse or parent? What are maybe some other things that you have seen work?
So it's complicated because what's approved for adults isn't necessarily approved for teenagers. And we have ongoing studies looking at things like ketamine, either delivered intravenously or nasally, looking at that for severe depression. There's a study of looking at propofol at the U and how that affects depression. However, it's also worth saying that in terms of therapy, we like to compare it to a pair of jeans. It's very hard to find the right pair of jeans that fit. And there are so many different models of therapy that exist, that some are more effective than others. So for instance, kind of the gold standard for therapy as far as treating self-injury is dialectical behavioral therapy, which is actually very difficult to find because it's a relatively intensive therapy.
Explain what that even is.
Yes.
Because some of us might not even know.
So dialectical behavioral therapy, or DBT, consists of individual sessions, one-on-one with a therapist once a week. And then there's also group therapy once a week where you work on building skills. And so there are 4 modules of DBT. The first is mindfulness, so learning how to attend to the present moment, exactly how it sounds. There's distress tolerance, so coping skills that you can engage if, for instance, the emotions become too much, or you're in a situation where you can't really do anything. So how do you cool yourself down, both literally and figuratively? There's a literal way of doing it that we actually use in DBT. Emotion regulation skills, which is also what it sounds like. So being able to brainstorm, problem solving, things like that. And then lastly is interpersonal effectiveness, which is kind of one of my favorites because it's super helpful, not just for patients, but everyone in terms of talking with other people, fostering positive relationships, recognizing toxic relationships, and being able to advocate for oneself effectively.
Okay. Yeah. So this is a little bit more intensive. This seems like some of the treatment that my daughter got in day treatment and inpatient. She was inpatient at Huntsman Mental Health for 2 or 3 weeks.
Yes.
Okay. So there's different types of therapy. Are there other treatments that, like, besides medication? Is there, like, did I hear you say something about stimulation?
Yeah, transcranial magnetic stimulation, or TMS. It's been around for several years now, but has not been examined a whole lot in teenagers. Back at Minnesota, where I was previously, we actually were running a trial of TMS for adolescents. Which I don't think that study has even finished running yet. It's the study that never ends. But there's a lot that's still in need of development, specifically for children and adolescents. Things tend to move a lot more quickly for adults, since it's actually quite a bit easier to study adults. And so there's a lag as far as research that kind of brings that down to the adolescent level.
Right. More red tape and liability.
Yes.
Well, I think it's interesting to talk about different options because, again, when you're dealing with mental health issues in crisis, and especially suicide, sometimes you feel like therapy just doesn't work for some people, and or medication just doesn't seem to work for some people. And we want to know what other resources, what other things, because you get desperate. You're like, I'll try anything.
Yeah. And with regard to both medication and therapy, most therapy that exists out more broadly isn't as structured or isn't quite the therapy that we use in research settings in terms of what we consider evidence-based. So DBT was one example, but also cognitive behavioral therapy, acceptance and commitment therapy. There's a whole lot of therapies that exist that seeing one or two therapists doesn't necessarily mean that therapy is not going to work for you. It's all a matter of finding the right therapist and the right type of therapy, which is kind of where the idea of, figuring out what treatments work for whom, that whole idea comes in.
What are the main types of therapy then? I mean, is it broken down into 2 or 3 categories?
So most of the time we see supportive psychotherapy, which is also just, I guess, colloquially known as talk therapy, where there isn't exactly a structure, so to speak. It's more of talking and can be kind of insight oriented in a way where you sort of just talk out your problems. So
this seems to be the broadest base of therapy.
Yes.
Right? Okay.
Whereas the types of therapy that we study more explicitly in research settings, such as cognitive behavioral therapy, things like that, it is more, I guess, it involves more on the part of the patient. So for instance, there's typically homework assignments because therapy is 1 hour in a week. So there's a lot of encouragement of engaging in new coping behaviors, trying to build these new habits over the course of the week, and then checking in the next week, seeing how it went, and so on and so forth. And basically being accountable to someone and being very explicit about what are the skills that you're learning, so that you can you can see progress over time a little easier. And I think that helps a lot with people being able to see that they're getting somewhere.
Right. Okay. So I want to get back a little bit to the self-injurious thoughts and behaviors. And we talked a little bit about what do you look for?
Mm-hmm.
So now if I see those, where do you go with that?
Yeah, that's a great question. That also varies depending on the individual. With teenagers, there are some teenagers who definitely do want help, whether in the form of therapy, medication, or maybe being in touch with a counselor at school. And then there are some who might be more resistant to help, which then it's a little bit trickier. One of the things that we have been noticing in some of our preliminary SafeUT research is that although we might not want to think that this is the case, it appears that parents are a significant barrier to seeking mental health treatment. Most of the time it's because kids don't want to share this information with their parents. And so being able to have access to a resource that you don't necessarily have to go through mom and dad for can be super helpful. So I guess this is a nice segue into SafeUT.
Right.
SafeUT, as a little bit of background, is an app that is available to students in the state of Utah that you can download, and you can use it for crisis text line. There are master's level clinicians on the other side, and it's text-based, which is nice because no one talks on the phone anymore, although you can call if you want to. And there's also what we call a tip line where, for instance, friends who are concerned about someone in their group as far as their safety, for instance, they might leave a tip in which they identify who that friend is, what they are concerned about, and what happens is that either a clinician on the other end of SafeUT tries to get in touch with that person, or, for instance, if it's in a school setting, it will get relayed to the school for the school to then manage the situation.
And how are you involved in SafeUT?
So I'm part of the research and quality improvement team, which is a pretty fun part of SafeUT, I would say, because we get to collect data and really check and verify that the service is making a difference, and also learning about how we can do better and actually implementing those changes, and then relearning things like that.
So what are you seeing from the app? I mean, is it being utilized? Is it accomplishing the goals of those who created it?
It is. It's a very positive response so far. We did a survey, I can't remember how long ago now, but we asked school administrators who were involved in SafeUT of their perceptions of the app, and by and large, most were very positive and had noticed an improvement in things like stigma and levels of anxiety in school, and also levels of concern going down, knowing that the service is available for students. Another thing that we have noticed preliminary with some of the data we've been collecting from the users themselves is that for the most part they are feeling very supported, and we also see so far we've been seeing a significant decrease in, say, level of suicidal ideation before and after the chat, a difference in like anxiety, general distress, things like that. So we're seeing very positive things so far. The one area in need of growth is definitely more campaigning and getting more lower utilization areas, such as rural areas in the state, bringing more awareness of SafeUT in those areas in particular, where we see that students aren't engaging in the service as much.
Right.
Yeah.
What advice do you have for students and adults who might be struggling with, SITBs or other mental health issues that are afraid to even use SafeUT?
Mm-hmm.
Like, if you could just give them advice at home, what would it be?
I mean, it's really hard to do it alone, the main thing. And also the awareness of not being alone. About as many as 20% of teens, for instance, have engaged in self-injury at some point in time, which is a pretty significant percentage.
1 out of 5.
Yes.
Yeah.
And it's important to let someone in, and ideally that someone is a trusted adult. One of the things that I often really encourage is that if there is, it doesn't have to be a parent, but a teacher they feel comfortable with, for instance, or a aunt or uncle that they feel comfortable with, that those are points of contact that they can confide in. Of course, it's going to vary as far as how they're going to respond, but it's a nice stepping stone in that direction. And usually people are decent judges of character, so chances are if you're identifying that person as being someone you can trust with this information and trust to help you, chances are they're going to have your best interests in mind as far as what they do with that information.
Why do people self-injure?
The reasons are many. The main overarching reason is to regulate negative affect, which, to put more plainly, is basically to reduce feelings of just intense emotion, usually negative emotion. There can be a brief period in which that intensity goes down as a result of self-injury, which is, and some people also use it as a form of coping if they're feeling numb, like they feel disconnected from reality. It can help them feel reconnected to reality. The reasons are many, but for the most part, it has to do with coping with negative feelings or emotions.
When I discovered that my daughter was cutting, that was one of the questions I asked her, is like, why do you do this? Mm-hmm. And she said, because I want my physical pain to match my emotional pain, or be more so that I can know that it's something I can control. And if the pain physically is worse than the pain mentally or emotionally, then I feel like I'm in charge of it, kind of thing. And that's hard because, I mean, like when I was her age, if I got mad, I wanted to harm other people, yes. But mostly it would be like, I just would get a pillow and just, punch the pillow or something. And because I didn't want to hurt myself.
Yeah.
I was like, that hurts. I don't want to do that. I just want to like punch a pillow. But what are some things that, and now my daughter stopped cutting, but now she gets tattoos because it hurts, and it's now her new therapy for, and that's a different story. But what are some things that people who struggle with that? What can they do to maybe redirect that? What an alternate treatment? Yeah,
that is pretty tough in terms of what to do kind of instead, which is an important goal of therapy, is figuring out, okay, what can you do that serves that same function? Like, so if your goal, for instance, is to say have a physical indication of the pain you're in, is it maybe drawing on yourself instead, or just drawing in general to have an outward expression of how you feel internally? It could be something like, just reaching out to a friend, trying to find really specific examples of things that they do enjoy doing that are accessible and basically achieve the same goal that cutting would. which is tricky and varies from person to person.
Yeah. So I guess as an expert, you have to figure out what is the motivation behind the self-injury. Mm-hmm. What is the reward that, or the feeling that they are trying to accomplish, mm-hmm. and then see if there's ways that are not harmful, mm-hmm. that can do that. I know a lot of people will go to the gym.
Yeah.
It's like, okay, well, if I have all this energy, I'm going to just kill my body. But we're, in a more mm-hmm. healthy manner, or maybe go for a run or.
Yes, exactly. And it takes some experimentation in a lot of cases and that's sort of what I mean by, therapies having homework. For instance, sometimes we create a list of different things that they can try. And it's like, okay, when you notice these things, what you're going to do this week is you're going to do this instead of the harmful behavior. And then we'll check in to see how that went next week. And that accountability to the therapist and being like, oh, I need to at least try this thing.
Right.
And also potentially discovering a new way of coping that's more adaptive and healthy. That process can be particularly helpful.
I'll tell you what's not healthy: eating chocolate and sweets. Not healthy, guys. It might be a good way to cope, but it's not a healthy way. And I'm guessing that there's different ways. A question I just thought of is, I have a 4-year-old who I adopted, and he was born on meth and different mm-hmm. drugs, and he started hitting himself. Mm-hmm. Like when he gets mad, he starts hitting himself, and it just blows me away. Like, is this an early sign, warning, indicator? Are there things now, if somebody notices that one of their smaller children are kind of like, they start to hurt themselves when they get angry or mad or upset?
Mm-hmm. Yeah.
Help.
So that is, one of the tricky things that we've been encountering in this work is that we see what I guess you might call neurotypical individuals engaging in self-harm behavior. And then there are individuals who may have developmental disorders, like they were exposed to drugs, for instance, and their brain development has been impacted in some way. They're like disorders such as autism spectrum disorders, for instance. Self-injury can sometimes be relatively common. However, we often look at those in isolation from one another. However, in quite a few ways, the function is the same, in that usually it has to do with how they're coping or handling some distress in their environment, whether that be frustration with whatever the situation is happening or a change, things mm-hmm. like that. So yeah, that's a good question. And the answer is that we're not very good at bringing together looking at the whole spectrum, so to speak, of self-injury.
Yeah, it's interesting. I mean, it's something that it struck me because I just thought, I know kids throw fits and do different things, but this is starting to be a little bit more regular. Mm-hmm. So I'm, I guess, being mindful of it. And then it would be something that I should maybe talk to his pediatrician about as we move forward to just.
Yeah, that's not a bad idea. A pediatrician is a great place to start as far as figuring out where to go, getting the referrals you need, sort of the gatekeeper in a way of pointing you in the right direction.
One of the things that my daughter learned in her inpatient and day treatment were coping skills. Mm-hmm. Again, for people who are just looking for, hey, can you give me 3 maybe of the top coping skills? Would you have some advice on that? Like if you're feeling depressed or suicidal or whatever, these are maybe the top 3 things you can do.
So I'll start with, I guess, a more intense coping skill, which comes from dialectical behavioral therapy, DBT, which involve it's what we call TIP. So temperature, intense exercise, and paced breathing. So for the sake of time, we'll talk about temperature more specifically. But this skill actually involves you sticking your head in a bowl of ice water. So
I wouldn't mind helping my kids with that.
Yes. So, and it has to be, like up to the ears, not past the ears, but to the ears. And the purpose is to have your body engage in the dive reflex, which then calms your body down, basically.
Okay. So the ice water in the face.
Yes.
Okay.
Yeah. And
that's your temperature part of the tips.
Yes. And then, so intense physical exercise is the I. So
maybe jumping jacks or
yes, exactly. Exactly. So that kind of gets to what you were saying before, how some people, go to the gym. Mm-hmm. It's similar to that. And then the P includes paced breathing. So that is breathing in for, say, 7 seconds, breathing out for 8 seconds. It can be whatever seconds you want, because some people, it's different for different people. But the idea is that the amount of time that you spend exhaling should be longer than the time that you spend inhaling, because that will help decrease your heart rate, calm you down.
Okay.
Yes.
So tip.
Yes.
Tip is the first coping skill that comes to mind. That's temperature, intense exercise, and breathing.
Yes.
What was the P?
Paced breathing is what we call it.
Yeah. Okay, that's a good one. What else?
Another coping skill is, wow, these are hard to think of on the fly.
I know the one that made the biggest difference with my child was radical acceptance.
Yes.
So maybe you can explain that a little bit and what that means and looks like.
Yes. So radical acceptance is hard because it's all sort of a frame of mind. But essentially being okay with things as they are and recognizing that pain is inevitable, for instance, whether that be physical pain, emotional pain, it's going to happen. But suffering is optional. So moving forward, accepting things as they are, and, focusing on either how to move forward or what you can do to change the situation.
Okay. Yeah, I thought that was good, because I'd be like, oh, hey, guess what? We're moving. And she's like, okay. I said, what was that? Radical acceptance, Mom. There's nothing I can do about it. Doesn't matter what I do or say. It's not going to change it. So I just need to accept it and figure out how to cope. I'm like, yes, I love this program.
That was a much better, much more concise, understandable description than I gave. So I highly recommend your description of radical acceptance.
No, I just feel like there was a few things. So is there any other coping skills that maybe come to mind that somebody can use on themselves or, help other people use?
I actually spend quite a bit of time helping people explore the coping skills that they already are doing. They're just not aware that they're doing it. So this might be a creative exercise, for instance, or say something that they might tell themselves when faced with certain situations, mantras, basically, trying to figure out okay, what is a time that, say, you got stuck in this negative thinking, and when you got stuck, how did you get out of it? And of course, focusing on how did you get out of it without doing negative behavior here, and exploring what it is that they did. Sometimes it's, getting out and exercising. Sometimes it's cleaning the house, organizing things is also an activity that I sometimes patients, they find helpful. Writing down lists is a nice active thing if they're just feeling overwhelmed about, say, what they have to do. Right. And it's just, they get in sort of this freeze anxiety state. Writing down, say, 5 things that they can do, and focusing on those 5 things. So there are many different coping skills that vary from person to person.
I think what I like the idea of, like creative brainstorming, seeing what you're already doing.
Mm-hmm.
And again, I'm no expert by any means, but I do know that with my daughter, we had things that I can do when I start to feel this. If I start to feel upset, what are the top 3 to 5 things that bring me joy or happiness or redirect my attention? For her, it's art. She loves art and animals and plants and things like that. So when she starts to feel that way, sometimes you have to like focus on it. And then I remember when she got discharged, they gave us a safety list. And I think that might be something that could include, if I'm feeling this, I should do that. And something that you give to somebody in your space.
Yes.
You know, like what does that look like? What do I do? How do we cope? And
exactly. Because it's sometimes hard in the moment for you yourself to engage and remember that, say, that safety plan exists.
Right.
So having someone who can basically like, hey, there's this thing that you did, let's focus on that.
And doing that when you're not in a state of elevated anything, because our natural reactions are flight or freeze.
Yeah.
And whenever your stress levels are up, you're going to respond one way or another. So being able to sit down in a calm, collective manner and say, what triggers me? What doesn't? What relieves this? What doesn't? And then having that available, because when you're in the heat and the moment, it's like,
yes.
blah, I don't know, leave me alone, I hate you.
Yes,
and then it's like,
exactly.
oh wait, hey, let's play some music.
And that's essentially what the safety plan is it's there to help you when emotions are running high and you can't exactly think very clearly. And ideally, and most of the time, these safety plans also include people to contact too. So it's not just things that you can do, but there's a variety of things on there, which is nice because, it could be 3:00 in the morning and not exactly possible to reach out to someone at that moment.
Right.
So having that list of resources that's kind of provides you with a variety is super helpful.
I have one final question that I think, I know when we were leaving Huntsman Mental Health, they didn't allow the kids to share contact information so that they could maintain relationships afterward. My daughter has a couple friends who also struggle with self-injury, with suicidal ideology, and it's hard for me, and I think it would be hard for any parent in this situation. Like, my daughter's going, well, I need to be there for my friend who's dealing with this depression, anxiety, suicide, talking about it. And I'm noticing her kind of spiraling back down. So what is the recommendation for allowing these, that's her friend. She feels like she needs to be there for them. I feel like it's more harmful.
Yeah.
I don't know the boundary, and I think most parents might not know the boundary.
Yes. Boundaries are extremely important and very hard. I mean, it's hard for adults even to figure out where that boundary lies. So it, again, can take some exploration and figuring out what is the point in which I need to step back. For instance, this might be, some signs might be, okay, I'm having a hard time coming back from that situation. Like, I need to step aside. I need to direct them to someone else. It's okay to say that you aren't really equipped to have that conversation at that moment, or that it's difficult for you right now. And being honest about it, it's extremely hard.
Well, we just don't know whether to force them not to have the relationship right now, because it seems like it's worse for their mental health to be surrounded by other people who are struggling, or if it's better. What's the science on that?
Yeah, so to bring things back to rumination again, there is what we call co-rumination, where people do it together. They start ruminating as essentially a unit, which we see particularly in teenage girls, and in situations similar to the ones that you described. So not getting caught up in, the why questions, like why me, why you, why this, why that, and checking in and being like, wait, I'm going down that road again where I just get stuck.
Yeah.
What were the things that I learned that helped me when I was stuck before? And this is, of course, difficult without, therapy kind of pointing these things out. But just stepping back and be like, okay, how can I make this situation better? How can I be supportive without sacrificing myself? I tell my patients this analogy all the time, but there's a reason why when you're on a plane and the air masks come down that they tell you to put yours on first before helping others. So it's super important to make sure that you are taken care of, because you're not going to be particularly helpful if you're also struggling.
Right. And that's the hard one, because if you put them away, it's like, well, my friend needs me, and how could you do this? But if you let them go there, then they're bringing it. It's just hard. It's like a no-win situation.
Yeah, there are a lot of those.
Well, thank you for the information on that.
You're welcome.
So for somebody listening right now, if they're struggling and they know that they do some of this, but they've been able to hide it, what would you want them to know?
Again, is that you're not alone. And there are people who are, for lack of a better word, desperate to help, who are really committed to helping. And, it's really hard to see that depending on the place that you're in. But we also know that when you're in this space where you're engaging in these behaviors and having these thoughts, that it's really hard to see beyond what the thoughts are telling you. Because with depression, for instance, it lies. Anxiety lies. A lot of mental health difficulties can kind of be thought of as thoughts that are telling you lies, so to speak. They tell you that you're not worth anything, that, no one is there to help, but, you definitely are worth everything, and there definitely are people available to help. And it doesn't have to necessarily be, a professional. Like I said before, it can just start with one person that you feel comfortable with, and you can work your way from there.
So don't be afraid. Don't listen to the lies. Don't be afraid to reach out, even if you want to be anonymous, right? What do you think here in Utah what do you think we can do to lower our suicide rate?
A huge barrier that we're running into is availability of mental health providers. There's a massive shortage, for lack of a better word, and it's only going to get more significant as time goes on. So being able to provide resources, particularly like in rural areas that are more difficult to access, I think maybe the one good thing, if you can call it that, from the pandemic is teletherapy. And we found in some of our research so far that it seems to be working just as well as in-person therapy. And that shows us that, someone who is located in one corner of the state, one isolated corner in the state, could get services from a provider who is in Salt Lake, for instance, being able to access. So they're not limited
geographically.
Yes. So then it still comes down to, the availability of providers. So when it comes to students, National Guard members, and first responders, SafeUT is at least kind of a stopgap for that, in that it does provide that service 24/7, and it's readily accessible when needed. But outside, we need to continue thinking outside those demographics, and even within those demographics still, how we can better provide for the people in Utah who are struggling.
If you could wave a magic wand right now, a magical mental health wand, what would you do?
I mean, how magical is it? Like every time?
Very magical.
Like, as in it just, like, mental health distress just goes away? Or are we, like, talking about, like, you know, maybe...
Well, that would be ideal, right? Like,
Yeah.
obviously, if everybody... If all of our brains just function properly all the time and we're great and healthy, that would be amazing.
Yes.
In light of that, we know that we're going to have mental health struggles, but if you had a wish for this, you know, epidemic in itself, like the mental health and suicide and stuff, what would it be?
It would be more caregivers, more providers. We need more therapists. We need more psychiatrists. We just need more people in the mental health field. And that has largely been a challenge given the stigma associated with mental health, as well as other jobs, whether in the healthcare industry or other industries in general, being a lot more maybe lucrative than the field of mental health. So being able to attract and retain talent, so to speak.
Do you love what you do?
Yes, I do.
And what would you tell someone who's maybe on the fence about it, a career in what you do?
I mean, I would say many things. I would say it's extremely rewarding, and it's also extremely hard at times, but I've loved what I've done as, like, ever since I got involved in mental health, ever since graduate school. I've absolutely loved what I've been doing because it's a very gratifying experience. Even though there are some times where you kind of feel like you're just hitting your head against the wall, there is also a lot of good that you can see. And there's also a lot of potential for growth too.
Knowing that you're working on something that literally impacts everybody, because whether you struggle with it or not, you know someone who is. And whether you think you know or you do know, they are.
Yeah.
Like,
yes.
You know, one of them said every single person struggles with mental health. Some of us just cope better. And so knowing that you're doing something that matters, and the research, and maybe you'll discover something that can really help end some of this suffering, that's probably going to make you feel good. Makes it all worthwhile.
Yes. And I also work specifically with teens too, and I absolutely love working with adolescents, and I kind of always have. So just working with that generation is...
Why?
They give me a lot of hope for the future. I just am kind of in awe with how involved a lot of today's youth are, and how active they are, and how motivated they are about wanting to see things be better than they presently are. And so seeing that just makes me really excited, and I just kind of want to be their cheerleader and helping them achieve the goals that they have, because, you know, they're incredible people.
It's nice to hear that perspective from somebody, because sometimes as a parent we just get bogged down. You know, we see the difficult side sometimes, and I know that this generation is really incredible. What is your final parting message? Is there something that you want to leave the audience with?
I guess one of the main things is that, as you said before, you know, everyone has mental health. Just some people have more difficulties with it than others, similar to physical health. And opening up more of those conversations is really important. Having conversations about how you're doing, things like that. When people ask you, like, how are you? Maybe pause a second before you give your knee-jerk response.
And might I add to that, you're not allowed to say fine. Okay, this week when somebody asks you how you're doing, don't say fine or good. Don't give a canned response. Maybe actually think about it and tell them. I usually just say fine.
Yes.
But, every now and then somebody's like, how are you doing? I'm like, actually, I'm doing horrible, and here's what's going on. And they're like, me too.
But forewarning, it might take people off guard. Yes, because they're not expecting to have an actual conversation. But hey.
But maybe they need it. I don't know. We all need it sometimes, right?
Mm-hmm. Yes, definitely.
So don't bottle it up. Be open, be honest, find a trusted resource or person. And what we're hearing is like through SafeUT and some of these things, there is always somebody available, right? Mm-hmm. Okay, well, you don't have to do it alone. Pay attention to these behaviors. Dr. Mindy Westlund Schreiner from the University of Utah, thank you so much for coming in, and thank you for your research, because what you guys are doing really does matter.
Thank you.
Thanks for tuning in to Mental Health Helps. If you're an expert or you have a story you would like to share, please reach out to us at gooddeedrevolution.org.